So this is my attempt at doing a presentation on COVID, the new coronavirus, as well as talk about its interaction with the ACE2 receptor. The SARS COVID-2 virus has taken over the charge of our day-to-day life and has altered the way in which we work. And there is an important interaction of this virus with a receptor that is involved in blood pressure regulation. A lot of patients are on blood pressure medications, and these medications increase the number of ACE2 receptors, making someone susceptible to infection. So the purpose of this YouTube podcast is not to create panic, not to do any fear mongering, but primarily to educate the people who are taking antihypertensive medications, especially ACE inhibitors and ARBs, which increase the levels of the ACE2 receptor through which the virus gains entry into our lungs. In terms of my disclosures, I am a part of the fasting method and the intensive dietary management along with Jason Fung and Megan Ramos. I'm a low-carb advocate. I have been incessantly trying to promote the root cause analysis and lifestyle changes in promoting health. And this is not individual medical advice. Always consult with your physician. So today's presentation is about how the SARS COVID-2 virus gains entry into the lung. It is through the ACE receptor. And as I mentioned, certain blood pressure medicines such as ACE inhibitors and angiotensin II receptor blockers increase the number of ACE2 receptors. And hence the question that comes about is that should we change from these medicines to something else to manage the blood pressure? I'd like to tell you right off the bat that I don't know the answer, that the experts in this field disagree, and that the major heart associations have come out and said that if somebody is on these medications, not to change the medications, but don't start new individuals at risk of getting the COVID virus on these medications, which I presume is almost everyone. So what are these medications? So the angiotensin II receptor blockers and the ACE inhibitors that increase the number of ACE2 receptors can be divided into two categories. One is the ACE inhibitors, and I have listed them. I will not go through them one by one. But perhaps the one I use the most is Enalapril and Lisinopril. And the angiotensin II receptor blockers, which block the angiotensin at a different level, are the medicines like Losartan and Valsartan that I use quite often. And one of my friends is on Telmisartan, and he was quite conflicted because he is a surgeon. He got the COVID virus infection and he was not sure what to do. And in order to tell you that I don't know the answer, I told him that I cannot advise him. But that does not mean that I do not give you the information with regards to the science behind it and what the conflict is. So the ACE2 receptor that is increased with these drugs, some of the drugs are shown on the screen, which is the Captopril, the Enalapril, and I put up pictures out there so that people can recognize. So in this slide is the SARS COVID-2 virus shown, and out here is the ACE2 receptor. the SARS-2 COVID virus has these glycoprotein spikes. The glycoprotein spikes interact with the ACE2 receptor, and this is my version of how they potentially may. And once there is interaction with the ACE2 receptor, the ACE2 receptor and the viral complex is internalized. The virus then takes over the protein and the RNA manufacturing machinery inside the cell and replicates itself, destroying the cell and causing infection and causing lung injury. Now, I don't want to beat this point to death, but it is important to recognize that ACE2 receptor is crucial for the virus to gain entry, because I'll show later that without the presence of this ACE2 receptor in ACE2 receptor knockout mice, the virus was not able to get infection in those mice when exposed, and I'll show some data on that. But the use of these drugs that are used to treat high blood pressure, perhaps about 50% of adults are on these medications when they have high blood pressure. When it's used to treat diabetes, perhaps a near 100% of diabetics are supposed to be on these medications in order to prevent kidney injury from diabetes. And many patients with kidney disease, heart disease, and congestive heart failure on these drugs. So there is a substantial proportion of adults throughout the world who are taking these drugs. And when you take these drugs, there is an increase in the receptor to which the virus interacts, and that can increase the risk of infections. Now, I've always been highly critical of my own profession, and since I'm a physician, I feel like I have a little bit of liberty in doing that. The reason I say that is that mainstream medicine is in the habit of labeling something bad when they have a drug that can alter it, and labeling something as good when both of these are mechanisms that the body is using to do certain important functions. So like, for example, angiotensin, which the blood pressure medicines try to block, specifically angiotensin II, and reduce blood pressure, angiotensin II has very important functions in our body. I tell my patients to fast. I tell my patients to exercise. And when they are doing that, their blood pressure may fall. When they are exercising, they may lose salt. Angiotensin is an important regulatory product that our body makes so that salt retention can happen from the kidneys. It tells the brain through certain centers to increase thirst, and hence it can control blood pressure. So it is not necessarily a bad player, and whenever the body makes a certain substance, it is always counter-regulating. It makes counter-regulating substances to keep that angiotensin II, in this case, in check. So here is what angiotensin II does, which is that it makes you drink water, prevents salt loss from kidneys, increases blood pressure, and at the same time, it comes back and tells the ACE2 receptor not to make certain different kinds of angiotensin peptides. By the way, angiotensin is a peptide, which means it's composed of amino acids. And in the angiotensin II, there are 8 amino acids. When you break down angiotensin II with ACE2, you get a heptapeptide, which is a 7 peptide. It's called angiotensin 1 to 7. Now, this drops blood pressure. It also has the potential to reduce lung injury, as we will see. So the angiotensin II is not only helping us maintain our blood pressure, but it is regulating other substances that can potentially drop your blood pressure. However, when you block angiotensin II, this inhibition of ACE2 receptor, ACE2 receptor is reduced and ACE2 receptor goes up. And this has been shown in several human as well as animal studies. So, briefly, to look at what angiotensin II does, is that it causes the constriction of blood vessels, increasing blood pressure. It causes endothelial dysfunction, which means that it upsets the lining of the stomach. It's involved in growth. It can lead to plaque buildup. It can cause blood clots to form. Those are some of the bad things. The angiotensin 1 to 7, which is a heptapeptide, 7-peptide made by breaking down angiotensin 2 through the ACE2 receptor, does certain things through another receptor, that is making the blood vessels larger, dropping blood pressure, promoting the health of the lining of your cells, reducing blood clot formation, and other things. So in this next slide, I'm showing that here is angiotensin II that is increasing blood pressure and making the blood vessels smaller, regulating blood pressure. And similarly, there is ACE2, which is controlling the actions of angiotensin II through other peptides, as I have talked about. Now, we talked about the fact that the SARS COVID virus gains entry into the cell by attaching to the ACE2 receptor. And we also talked about the fact that the ACE2 receptor goes up when you block the actions of angiotensin II. Hence, you would make somebody who is taking these blood pressure medicines more susceptible to infection. However, that's not the complete story, because my goal is to give you proper balance. And the balance is provided by telling you that blocking angiotensin II while increasing the susceptibility for infection, the blockage of angiotensin II may do certain things that would prevent severe lung injury. In fact, this group did studies in mice in whom they found that blocking the effects of angiotensin II reduced lung injury in animals that were infected with the SARS-2 virus. So here is a study that I have labeled out here. The SARS COVID spike gains entry into the cell through the ACE2 receptor. It downregulates the ACE2 receptor. And when it downregulates, it increases the amount of angiotensin II, which can lead to lung injury. And in order to reiterate that the ACE2 is absolutely necessary, when this group took ACE2 knockout mice and gave them infection with the virus, the viral titers were undetectable in most of these mice, or were at very low levels compared to the wild type mice who were readily infected. And when you looked at viral products of viruses inside the cells, when they were infected, you could see that the wild type mice had a high number of viral products, whereas the ACE2 knockout mice did not. So hence, even though I'm raising the question, should we be taking these medicines? Should we stop them? I put this slide up to show that if you are taking an ACE inhibitor or an ARB, a blood pressure medicine that blocks the action of angiotensin, you may actually reduce some lung injury despite increasing your risks of infection with the SARS COVID virus, as I'm pointing out here. Now, this has overwhelmed our society so much that about 1,000 patients who were infected with this virus were studied in China in 2019. And so these are about 1,099 patients from 552 hospitals. And they looked at who amongst these patients were admitted to the intensive care unit, had to use mechanical ventilation, which means that they needed a respirator to breathe, or died. And what we find out here, and I need to take you through the slide, this is the presence of disease. Here the disease is not severe. Here the disease is severe. Here are the number of people who are getting on a ventilator or dying. So that's the composite endpoint. And what we find is that the highest percentage of people who had both the severe and the non-severe infection were hypertensives. Presumably these would be patients on the drugs that we mentioned. The highest proportion of patients, or the second highest, were diabetics. Diabetics are on these medications. The third highest proportion belonged to patients who had heart disease. And not only was it true for non-severe disease, it was more true for people with severe disease as well as people who ended up on a ventilator or dying. So here is my take. My take is that should you stop an ACE inhibitor or an ARB? I don't know that answer. And I don't want to pretend that I know it or anybody knows it for sure. We simply do not have the data. And I don't propose that you stop your medications without consulting your physician. But over the last 6 years, I have focused on root cause analysis. Like my friend Ivor Cummins says, and I did this podcast with him so that it would gain a lot of traction. When I put up a YouTube video, I get very few views, whereas Ivor is quite popular. And I thought that this was an important message for me to get out. But the way we should think about treating hypertension is by going to the root cause. Are you insulin resistant? Are you eating several meals a day? Because one of the best ways of becoming insulin resistant, if you look at some of my other YouTube videos, is by eating frequently and having persistent and frequent increases in your insulin levels. Do you practice intermittent fasting? Are you physically active, or do you have a sedentary lifestyle? Do you get enough sunlight? Sunlight is a very important aspect because sunlight not only makes vitamin D, which reduces your risks of having high blood pressure, but sunlight also increases nitric oxide, which is important for reducing blood pressure as well. Are you vitamin D deficient? Are you vitamin K2 deficient? Are you entraining your circadian rhythm? By that I mean, do you spend time out in daylight during the day so that the day-night cycle is established in your circadian rhythm? Do you turn off the blue light? Do you stop watching screens? Do you have a blue light filter on your glasses? Are you sleeping better because you're darkening the room at night? So these are all important factors that I wanted to promote. And part of this is no question shameless self-promotion, because I belong to the fastingmethod.com, the IDM.com, and we have a fasting clinic. And we want to promote lifestyle changes that are looking at root cause analysis that will address high blood pressure, obesity, diabetes, malignancies, and many other Western diseases. So that's all I had to say today. And I hope that my message came out as balanced and without the potential of creating fear mongering. Thank you.